Hi, Dr. Brian Kaufman, a family doctor with CLL at ASH 2014 with my doctor, Dr. Tom Kipps. You want to introduce yourself?
Well, I'm Dr. Tom Kipps. I'm at the University of California at San Diego at the Moores Cancer Center. I'm very happy to join you here.
So besides doing a lot of the bench science and the actual clinical research, you've also been looking at some of the almost epidemiological community stuff and actually how CLL is being treated in the community, and some interesting findings. You want to share that with us?
Yeah, I think it's part of the CONNECT study, the CONNECT CLL study that was sponsored with help from Celgene. And I think that what we tried to do is to assimilate data not just from academic centers, but also from the community. I think it's very important to say that we sometimes think that what we do and what we say to do is going to be accepted by everyone, and that the efforts to treat patients in the community is going to follow suit, but that's not the case. Obviously, in the community you have practicing physicians that have their own experiences that can influence how they make treatment decisions. And they may also have very limited number of patients with CLL that allows them to build up a different sense that might be evolving over time with some of these newer treatments. Some of the surprising features is the heterogeneity in how patients are treated. And even though there are guidelines, not all the time you see these guidelines followed. One of the surprising outtakes too was how frequently drugs such as rituximab were used as a single drug, when in point of fact it's not been approved for that use because it seems to go much better with some other drug in combination, and hasn't really been studied as much as a single agent.
And the data there is pretty weak as a single agent, though I guess if you really push up the dose to 2,000 and some of the stuff that Susan O'Brien did several years ago, you got a little better response, but it still wasn't.
Yeah, and there's also,
much.
I believe there's no free lunch in any type of treatment, so anytime you have to push things up to higher levels, you worry about having other effects that could be harmful to the patient. And it's clear that I think the experience in treating patients with lymphoma has influenced this too. And in point of fact, in the treatment of follicular lymphoma, single-agent rituximab is oftentimes used. And so here I have another patient, I might as well use what worked before in this other patient, even if the patient did not have CLL. I think also it's been clear that there are differences between what type of patients are being treated in the community, and that's usually different than in academic centers, because if there's some travel involved, then obviously the more elderly patients and more infirm patients may opt to stay in the community. So just by and large, I think at academic centers, the median age of patients at diagnosis is significantly lower as well.
Interesting.
And so we've had in the past the development of all these chemotherapy regimens, and those have been developed at academic centers where there's a younger, fitter population.
I see where you're going with this, yeah.
And so what's happened in the past is that some of the regimens that have been worked out at these centers, when they're applied in the community to someone considerably older or who has significant comorbidities, they're not as well tolerated. And that has been a problem that has been increasingly being recognized. Now I think that the advent of these newer therapies, hopefully the therapeutic index will be improved so that patients will not suffer from taking chemotherapy inappropriately. I think it has, in a sense, given chemotherapy a bad name, because if you overuse something or use things inappropriately, you're not going to achieve the best outcome. But I think it's fair to say that if we are able to properly assess the patient and identify those features of the patient that rule out certain avenues of treatment, such as chemotherapy, and then exclude them from the exposure to chemotherapy, we're going to be better off because the patients who might benefit from chemotherapy could be identified. But all this requires a better understanding of the disease, better understanding of the treatments that we have, better understanding of how effective they are in certain patients, and trying to give the right type of therapy to each patient. I wish it were easier. We talk about personalized medicine, but really it's about understanding what we're trying to treat. And I think one of the luxuries we have at a center such as Moores Cancer Center is we see a lot more patients with CLL than are typically seen by any group practice. And so this has helped in terms of really building up the collective experience of not just me, but my staff and other physicians working there. And then we can discuss things too, and also share it with our colleagues in academic centers. So I think it becomes a different way of evaluating patients, which is taking advantage of where we are. So I don't fault the community physicians at all. I think they're trying to do their best. It would be hard-pressed to treat, various cancers and have an occasional patient with CLL show up at your doorstep, and you're leading a busy practice. What do? And you try to do the things that you're most comfortable with, which I think is partly what we're seeing in the CONNECT study.
So I have to comment on this, and people have heard this from me before, and it's based on the data out of Mayo Clinic and that Dr. Neil Kay did, and just showed a survival advantage to seeing a CLL specialist. And the first thing I always tell patients is put your team together, and you need a really good local oncologist, hematologist who plays well with others, and then you need someone who lives and breathes CLL.
I think that's correct, and one of the striking features that still I think we have to review the data, but I was shocked in the first iteration of the data of patients having a 14% mortality in the first year after diagnosis. To me, was a shock, because I certainly don't see that even with patients with advanced disease that we have the opportunity to see at the Moores Cancer Center. So I do think that is clear, and like anything in life, if you have something that's not public enemy number one in terms of its frequency, and it has complexity, and I do think that as physicians we always need to be aware that what we do to patients is not neutral, and that even the intention to benefit the patient does not equate to benefiting the patient, and that physicians actually can cause problems in their own right. I'm very sensitive to this, and I certainly think it's always useful to continue to reevaluate what we're doing and to see whether it's having the effect that we hope to have, and not just deluding ourselves that anything we do is going to benefit the patient. And that's the essence of doing clinical trials. I think that we always have to be very vigilant about how patients are doing, and be open-minded to the problems that might be engendered with therapy. But getting back to therapy-related decisions, it's also times, patients are now saying, well, gee, now with the advent of newer agents, why do I have to wait after getting diagnosed? I should just go and take some pills and be okay. Well, we're really not there yet. I mean, even though we've had some great advances, I would say that the future is even brighter than the present. If someone opted for FCR, chemoimmunotherapy 5 years ago upon diagnosis, would they have regretted that decision if they didn't need treatment? The vast heterogeneity in the clinical history of patients with CLL has told me, and one patient stands out to me in particular, a patient who was being recommended for allogeneic transplant. And we were able to advise the patient, well, hold the phone, your genetic features and everything indicate to me that we can follow this for a while. And so she had her brother's cells actually harvested, and I was able to follow her, and she's actually done well. It's been over 10 years, so that's not having to be treated.
Wow.
So that's something
that's pretty radical, yeah.
And so I'd like to think about this idea of watch and wait. It shouldn't be watch and wait or watch and worry. I say watch and anticipate for the new developments that are coming. And if you don't need to receive therapy and you're leading a very healthy life and without any complications or symptoms related to the CLL, I think it's best to leave well enough alone until we have data to indicate that earlier treatment is actually going to be in your benefit.
I have to thank you with that. And it just emphasizes to me why it's so important to have someone whose CLL is such a big part of their life. So in terms of their research and their interest in caring for patients. And thanks so much for what you do for the CLL community and what you do for me.
Thanks.
Thanks.